Okay, so what is it? Part 5 now of ECG and lab values. Part was it 3 or 4? The last part stopped at watching a video, of course. The nursing video where they were talking about the 5-step method to EKG interpretation. And I was comparing and contrasting the video that talked about 6 questions to answer versus the 5-step method. What is the rate? That's pretty much the same. Rate is number 1 on the 5-step method. Question number 4, what is the atrial activity? That's talking about the P waves. And this video talked about the P waves, the second thing to look at. And then the relationship of the P to the QRS, that was question number 5. That's number 3 over here. And then the QRS, is it narrow or wide? Question number 3 over here. It was 4 over here. And then the PR interval, it doesn't really talk about the PR interval on questions 1 through 6 here. But after watching this video over here, is very important to know the PR interval. So the PR interval is discussing watch the video again, but anyway, I'm just kind of trying to summarize it. If the PR interval is longer than 3 small boxes, 3 to 5 small boxes, then we're talking about heart blocks. So that was a take-home from that slide. There again, there's the 5-step method. Rate 60 to 100 is normal. When you're looking at the P waves, you're looking at, are they present? Are they upright? Are they smooth? The P to the QRS ratio, is there a P for every QRS? As far as the QRS, is it 1.5 to 3 small boxes? And the PR interval, is it 3 to 5 small boxes? That's what you're looking for. I'm just kind of snapped. Here's a atrial fib, a sawtooth, P wave, atrial flutter, sawtooth P wave. The rate is more than 300 beats per minute. The P waves are sawtooths. There's a P, 4 P's to every QRS. The QRS length is normal, and the PR interval is normal as well. And he said that that was a atrial flutter. And then with the PR interval being long, is 5 greater than 5 small boxes, and he said that that was a first-degree AV block. So we're going to go more into detail on that later on. So ventricular tachycardia. So with this video, we're going to kind of focus on the figure 13, 14, the examples of the arrhythmias, and let's see, this one was what? Ventricular ETAC, which was H. Let's start with okay, so I changed my mind. I'm going to go in the order of figure 13, 14, which is atrial fib. Let's make So we're going to go in this order because that's what was in the book. So we're going to start with atrial fib. And this is the picture of what was in the book, atrial fib. And here's a picture from our program's lecture. And so I'm going to go find a video that talks mainly about atrial fib. Okay, here's a very short one. Let's go ahead and look at this one.
Alright, in this video we're going to talk about atrial fibrillation, and AFib is one of the most common arrhythmias that you're going to see as an EMS professional out in the field. It's very prevalent amongst especially the elderly. So let's talk about what makes up an atrial fibrillation rhythm. So the rate itself is going to vary quite a bit. You'll see on your monitors that the rate jumps from maybe 70 to like 130 beats per minute. It's very irregular. And so that leads us into the regularity. It is a very irregular rhythm, as I just put it. And you can see here in the strip that each of these QRSs are a varying distance apart from one another. You'll also notice that there is no P wave. It's just this squiggly line that is not discernible as any major structure in the EKG. Because there's no P wave, there is no PR interval. And the QRS width is going to be normal for atrial fibrillation rhythms. So if you have no P wave, you see a squiggly line and the rhythm is varying quite heavily, there's a very good chance that you're looking at atrial fib.
EKG guy.
To fly a rocket ship, you need to be an optimist. No astronaut launches for space with their fingers crossed.
Okay. The EKG guy, he's kind of up here. So, see if we can find it different. AV blocks will definitely get. Oh, let's get AV. Let's see what we got here.
These include age, family history, smoking, high blood pressure, or hypertension and obesity. Also, if you have any of the following conditions, you're more at risk of AFib, heart failure, diabetes, or coronary artery disease. The more of these risk factors you have, the more likely it is you might experience AFib. Be sure to discuss your full medical history with your healthcare provider.
Atrial fibrillation is the most common type of cardiac arrhythmia. In a healthy heart, the sinoatrial node, or SA node, initiates all electrical impulses in the atria. In atrial fibrillation, electrical impulses are initiated randomly from many other sites called ectopic sites in and around the atria, commonly near the roots of the pulmonary veins. These unsynchronized, chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. Although the atrial rate during atrial fibrillation can be extremely high, most of the electrical impulses do not pass through the atrioventricular, the AV node, to the ventricles. This is due to refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate or heart rate is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. Reminder: P wave represents electrical activity of the SA node that is now obscured by activities of multiple ectopic sites. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. As the atria do not function properly, the heart puts out less blood and heart failure may occur. The most common complication of atrial fibrillation, however, is the formation of blood clots in the atria. As the atria do not empty completely into the ventricles, the blood may stagnate inside the atria and blood clots may form. These clots may then pass into the bloodstream, get stuck in small arteries, and block them. When a blood clot blocks an artery in the brain, a stroke may result.
Bad news, man. That was a pretty cool video. I like it.
As you'll be aware, atrial fibrillation or AF is one of the more common arrhythmias, particularly in the older patient age group, and it runs the risk of clot formation within the heart. But how does AF look on a 12-lead ECG or EKG? Well, that's what you're looking at here. And when you look at a 12-lead, it's quite useful to firstly look at the rhythm strip, which runs along the bottom of the tracing. You can see it there labelled V1 on the bottom left. This is because when you're trying to ascertain what arrhythmia it is, you get more complexes than in the leads above. Firstly, atrial fibrillation by nature, if untreated, is a fast rhythm. It's a tachycardia. What's happening is there is ongoing chaotic, disorganized electrical activity within the atria. They're fibrillating, and you can see this on the 12-lead. Instead of a flat line and a clear round P wave between normal QRS complexes, you can see this fibrillating, raggedy, undulating baseline. As said, the QRS complexes are normal, they're narrow. This is because the ventricles say, however the electrical activity is generated in the atria, as long as it travels down the normal ventricular route electrically, that is, down the bundle of His and the bundle branches, that's the quickest route through the ventricles, and you'll get a normal QRS complex. However, because the electrical activity is disorganized within the atria, it travels in an intermittent fashion from atria to ventricles through the AV node. Therefore, classically, you get this variation in gaps between the R waves or the QRS complexes. However, here's a tip. When atrial fibrillation is particularly fast, it's difficult for the naked eye to see that variation in the gaps. Even when you take the pulse, it's difficult to ascertain that irregularity. Therefore, take a piece of paper and lay it on the R waves on the 12-lead. Mark off 2 to 3 R waves. When you move the piece of paper along, if the heart rate is irregular, the subsequent R waves won't fit over those marks on the paper. If it is regular, they will fit. This is Dr. Richard Hatchett for FastLearnECG.com.
Okay, so with atrial fib, the QRS is normal but narrow. No P waves. At irregular heart rate. So I noticed they didn't talk much about the so let's take a look at the 5 questions. Where's those 5 questions? So the rate is irregular. There are no P waves. There is not a P for every QRS. The QRS is normal but narrow. and they did not talk about the PR interval with the atrial fib. Okay. Atrial flutter. The atrial flutter, you're going to have the sawtooth P waves. And what's next? Oops. Okay, so the next one we're going to do of the tachyarrhythmias is supraventricular tachycardia. So we already talked about in figure 13-14 atrial fib, which is A, and so now we're going to go to C, but we'll go back to the PAC, but I wanted to group all the tachyarrhythmias together. So now we'll do supraventricular tachycardia. And this is the strip right here.
All right, guys, imagine yourself sitting at home, relaxing, watching TV. Then all of a sudden your heart rate jumps up from a normal to 150 to 250 beats per minute. It's probably the most common and most scary experiences to go through. SVT is the topic today, aka the merry-go-round from hell. I'll explain the pathophysiology of why we call it this in just a little bit. But first, what exactly is SVT? Well, supraventricular tachycardia is episodes of rapid heart rate that starts in a part of the heart above the ventricles. Which makes sense because supra means above, ventricular means the ventricles, and tachycardia is heart rate over 100 beats per minute. So what's really going on in the body here? Well, as you guys know, the heart has one main pacemaker and two backup pacemakers. In this case, our main pacemaker, the SA node, fires like normal, but the problem is somewhere near the AV node area. The charge jumps from normal conduction and kind of derails and jumps the train tracks. Instead of going down to the ventricles, it goes right back into the atriums, essentially doubling the amount of beats per minute. It's kind of like a merry-go-round from hell. This is why SVT is so dangerous, because it's that merry-go-round from hell. It's super rapid and very, very deadly, making your heart go like extremely fast. So using our 5 steps, let's interpret this EKG. Step number 1 is the rate, 150 to 250. That's like super fast. Step 2 is the rhythm. It's regular, guys. It's evenly spaced apart. Step 3 is our P wave. The atriums are contracting, but it's usually buried in the T wave. Now, step 4 is our PR interval. Usually it's not able to measure because it's going so fast. And lastly, step 5, our QRS is normal and narrow. Now, the causes of SVT. What causes this merry-go-round from hell? Well, the main causes are quite simple. We use the 3 S's: stimulants, sepsis, and stress. So stimulants like caffeine, cigarettes, and alcohol, which I call the 3 wise men, but even exercise can stimulate the heart rate and make it go buck wild. Now, sepsis, just fancier words for infection in the blood, can cause fever and added stress to the body. Even stress like anxiety from normal daily emotional struggles. We have to read all these pages? But also diseases that put added stress on the heart, like CAD, that cause the narrowing of the coronary arteries and puts added stress on the heart. Or CHF, known as heart failure, increases blood pressure and puts pressure on the heart. And also myocarditis and rheumatic heart disease, known as rheumatic fever, both cause inflammation in the heart, and even COPD, chronic obstructive pulmonary disease, makes it difficult for the body to get oxygen, which ultimately adds stress to the body. So what are the signs and symptoms of SVT? Well, once again, they all stem from this low oxygen, this low cardiac output. We'll see classic complaints like,
I feel lightheaded or I may pass out. So we use our cool little acronym COLLAPSE to describe all the problems that low oxygen gives our patients. And yes, guys, we did spell it wrong on purpose, so please don't email us. Now, C is for chest pain, O is for oxygen saturation that is lower, L is for lethargy or fatigue caused by this low oxygen, A is from anxiety, usually caused by that lack of oxygen, P is for palpitations, that described as a racing of the heart or kind of feels like gallops under the chest. S is for shortness of breath or dyspnea, that difficulty breathing. E is for elevated ventricular rate or heart rate in general, huge indication of SVT. You're going to have a very tachy heart rate. D is for dizziness and syncope, which is also called fainting or passing out.
All right, so now that we know what's wrong, what are we going to do about it? So here are some nursing interventions and treatments, but first, what is the main patient outcome goal? Well, we always want to reset and restore the heart to normal electrical function. So we use non-drug interventions first. So guys, write that down, please. First things first, we use a Valsalva maneuver, also known as a vagal maneuver. We ask the patient to bear down like they're pooping. Now this elicits a vagal response and drops the heart rate. Now I've even seen people use ice packs around the neck, which can elicit a vagal response too, because they kind of like tense up. Now if that doesn't work, we use good old-fashioned pharmacology. So the first things first, adenosine will lower the heart rate immediately, but it'll actually stop the heart rate too, and the patient will die if we give too much. So before we give it, there's some things that need to take place first. For example, the patient needs to sign a consent form, the doctor needs to be at the bedside, there needs to be a crash guard in the room, the patient has to be on the EKG monitor as well as the cardiac monitor. Woo! That's a lot to check off here. And we got lunch. Perfect. Now, if the drugs aren't working, we can always opt out for cardiac ablation, which is basically just burning or freezing the cells in the heart that are causing the problem. Or we can do electrocardioversion, our little baby shock. It's only 50 to 200 joules of electricity. It's given to reset that SA node, the main pacemaker of the heart. Now, once again, cardioversion is mainly used for AFib or A-flutter, but also for SVT. We're always going to want to do a TTE, a transthoracic echocardiography, which basically is a procedure to rule out clot formation in the atriums. Before we shock the heart, we don't want to spread those clots all over the body. Now, a little NCLEX tip for you guys. Cardioversion is not defibrillation. Defibrillation is that supersized shock at 200 to 360 joules of electricity. It's usually done when we have deadly rhythms like VFib or pulseless VTAC. Now, lastly, when the patient is stable and they're going to get discharged from the hospital, we need to educate the patient about the prevention and limit of triggers. And remember, the triggers are the 3 S's: stimulant, stress, and sepsis. They also may be prescribed drugs like the B, C, and D, beta blockers, calcium channel blockers, and digoxin. All are given to slow the heart rate and keep that even rhythm. I call them the famous negative chronotropic drugs because chronos meaning time, so negative time means less beats per minute. Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial.
2 of your cardiac dysrhythmia interpretation workbook, and I want to talk about supraventricular tachycardia. So in an SVT, tachycardias are typically between 140 and 250 beats per minute. Now keep in mind, as I described in the earlier slide presentation on sinus tach, that if a patient is at rest and has a heart rate greater than 160, it's very unlikely to be sinus tachycardia, even if you see discernible P waves preceding each Q or S. So with an SVT, the onset is abrupt, and when we see it happen abruptly, we call it a paroxysmal supraventricular tachycardia, and I'll talk about PSVT shortly. But when we see a tachycardia like this, that's a sustained tachycardia with a heart rates between 140 and 160. P waves are usually not clearly discernible. Oftentimes they're buried in the preceding T wave, and sometimes you'll see a little notch coming off the descending portion of the T wave, and you'll see that consistently. And that may, you might call that a P wave, but don't mistake that for a sinus P wave. That's usually an ectopic focus that's causing this SVT. P interval is not applicable if the P waves are clearly not discernible. And the QRS is usually narrow, and I put an exclamation mark there because if you see a tachycardia without clearly discernible P waves and the QRS is wide, we have to assume that's a ventricular tachycardia. So a wide complex tachycardia without clearly discernible P waves is a ventricular tachycardia until proven otherwise. That's why it's very important that we only make the interpretation of a supraventricular tachycardia when the QRS is narrow, with some exceptions when we get into more advanced dysrhythmia interpretation. But easy, simple rule to remember is narrow, complex, regular tachycardia without clearly discernible P waves is SVT. If the QRS is wide, it's VTAC until proven otherwise. The ratio is not applicable if we can't see P waves, and the rhythm is regular, right? So this is not a compensatory rhythm. This is a dysrhythmia that has to be treated, and I'll talk about treatments of SVT in another presentation.
All right, my friends, Drew Canole back at it. I've been researching
Ventricular tachycardia in your cardiac dysrhythmia interpretation workbook. So let's talk about VTAC. Well, for starters, this is a wide complex tachycardia. And the rate is usually between 120 and 150, but you can have a slow VTAC as slow as 100 beats per minute. So between 100 and 120 would be a slow VTAC. Typically, VTACs are at the 120 to 250 range. Rates greater than 250 are considered ventricular flutter. P waves are absent, at least we don't see P waves preceding each QRS. If there was a P wave preceding each QRS, then of course we'd have to consider that this is a supraventricular tachycardia with aberrancy. So P waves would not be there present prior to each QRS and a VTAC. However, you may still see P waves, and if you do, look for P waves that are equidistant, firing at a slower rate than the heart rate, than the QRS rate. And when you see this, that's evidence that there's AV dissociation, where P waves are marching through. And AV dissociation is in fact diagnostic of VTAC. So what happens essentially is that in 50% of VTACs, and I'll just draw this out here, oops. So in about 50% of VTACs, we have an SA node that's firing at a rate of, well, let's just say arbitrarily 80 beats per minute. And a focus down here in the ventricles will say arbitrarily is firing at a rate of 180. And what happens is we'll see evidence of atrial depolarization on the QRSs. So again, I'm just going to draw this arbitrarily, it won't be accurate, but if you saw like a notch, evidence of a P wave here, and then one here, and then one over here, and so on and so forth, where these P waves appeared to be equidistant and disassociated from the QRSs, that would support the diagnosis of VTAC. That would be, in fact, diagnostic VTAC. In the other 50% of VTACs, there's a focus down on the ventricle, and it depolarizes the ventricle and the atria, so we don't see evidence of P waves. So if you do see evidence of P waves and they're firing at a slower rate than the QRSs, and they are not associated with the QRSs, then you've got AV dissociation, and that's diagnostic of VTAC. A P interval is not applicable. QRS is always wide at 0.12 second or greater, typically 0.14 second. The ratio is not applicable because there are no P waves associated with the QRS. And the rhythm should be regular, with one exception, and that would be the polymorphic VT, which means that a VT occurring as a result of multiple ectopic foci in the ventricle. One example of a polymorphic VT would be torsade de pointe, which means twisting of the points. And there's an example of torsade de pointe in the ECG exercises at the back of my book. So we'll take a look at that later. Now, the criteria for VTAC, short runs of VTAC, is simply 3 ventricular ectopic beats in a row. Let's see here. I thought I had numbered those. Good. So that would be a short run of VTAC. And so if you see 3 ventricular complexes in a row at a rate of 100 or greater, that would be considered a short run of VTAC. And the thing to remember clinically about VTAC, let me just go back to our previous slide here. So when you have someone in a VTAC, they can present anywhere along the clinical scale. Some patients will have VTAC and will be perfectly stable and asymptomatic. Some will present with shortness of breath and chest pain. Others will present hemodynamically unstable, and those are candidates for electrical therapy. And others still will present in full cardiac arrest. The pulseless and apnea can require full ACLS cardiac arrest management. Some have short bouts of VTAC, and as with sinus arrest and SVTs, what you want to ascertain is how long are these bouts of VTAC, how frequently do they occur, and what kinds of signs and symptoms does the patient have when they have these bouts of VTAC? Are they having syncopal episodes? Are they having shortness of breath, nausea, vomiting, chest discomfort? and important to report these when you arrive at hospital.
Introducing new personal plans from Nutrition.
Okay, this is a short video, but I got a doctor's appointment, so I'm going to shut it down here. So this video was mainly on tachyarrhythmias, atrial fib, supraventricular tachycardia, and ventricular tachycardia. And so that was A, C, and H. So we will do the other ones in another video.